Good morning, everybody. Thanks for joining us today for our webinar on MIPS. My name is Kate Tingley, and I am the Director of Marketing here at Coronis Health. Before we get started, I want to do a couple of quick introductions. Today's webinar is hosted jointly by Medicus and Coronis Health. Medicus is a leading provider of IT and cybersecurity services exclusively in the healthcare industry. They leverage their expertise to provide best practices and services available for optimizing practice workflow while remaining HIPAA compliant. If you'd like more information on Medicus, don't hesitate to reach out to Greg Toller, whose information will be sent out after the webinar, or take a look at their website. We will also be hosting another joint webinar with Coronis Health and Medicus on October 17th, covering ransomware and the implications on practices. As we mentioned, today's webinar is hosted jointly by Coronis and Medicus. So to give you a little bit of high-level information on Coronis, Coronis is a healthcare revenue cycle management and billing company. We were formed in 2015 with the idea to bring together billing companies that focus on specific specialties to form a new kind of multi-specialty RCM company with experts in each specialty. What makes us different from other RCM companies is that we have dedicated specialty teams working on everything from family specialties to neonatology and pathology. Coronis understands that just as no two specialties are the same, billing for no two specialties are the same. We understand the intricacies of each specialty and, most importantly, how to work with practices to increase collections and speed up payments. Our presenter today is Melody Jaju. Melody is the billing manager and resident MIPS expert here at Coronis. I'm going to hand it over to Melody now to jump right into the webinar. Over to you, Melody.
Hello, everyone. So we'll get right into it. What we'll cover today is the merit-based incentive payment system known as MIPS, the changes for year 2, overview of 2018 MIPS reporting requirements, reporting and data submission options, MIPS scoring, performance thresholds and payment adjustments, key metrics, and common pitfalls to avoid. MIPS combine legacy programs into a single program, the merit-based incentive payment system known as MIPS. In the past, Medicare Part B programs had 3 payment options: the Physician Quality Reporting System, the Value-Based Payment Modifier, and the Medicare Electronic Health Record Incentive Program. What MIPS does is streamline those programs into one performance-based system with 4 categories that are combined for a MIPS final score that determines Medicare Part B payment adjustments that we'll discuss next. MIPS is comprised of 4 scoreable categories: quality, worth 50 points, cost at 10 points, improvement activities worth 10 points, and advancing care information, which in 2018 is renamed to promoting interoperability, worth 25 points, for a final score of 100 possible points. So who is included in MIPS for year 2? Eligible clinicians include the following: MDs, DOs, dental medicine, dental surgery, optometry, chiropractic, PAs, NPs, clinical nurse specialists, certified registered nurse, anesthesiologist. Who else is included? The low volume thresholds have changed from eligible clinicians billing more than $30,000 a year and providing care to more than 100 Medicare beneficiaries to billing upwards of $90,000 a year and providing care to more than 200 Medicare patients. CMS increased the low volume threshold to ease the burden on smaller practices. Who is excluded? Well, this list lists some of the excluded clinicians that do not have to report: clinical social workers, certified nurse midwives, special language pathologists, audiologists, clinical psychologists. Who is exempt? Clinicians below the low volume threshold, newly enrolled in Medicare for the first time in 2018, or clinicians participating in an APM. An APM is an alternative payment model. We're not going to go over too much on APMs in this webinar. However, an APM is a payment model that deviates from traditional fee-for-service, which is the traditional process for reimbursing physicians for their services. Under the APM approach, practices are paid a set fee for each service delivered. If an organization adopts one of CMS's APMs, they agree to be paid according to the rules of that APM model, which is some variation of the Medicare Part B physician fee schedule or a new model altogether. To verify if you must report on MIPS, you can check your participation status through the Quality Payment Program website. How is 2018 special status calculated? Well, to determine if a clinician's participation should be considered as a special status under the Quality Payment Program, CMS retrieves and analyzes Medicare Part B claims data. A series of calculations are run to indicate a circumstance of the clinician's practice for which special rules under the Quality Payment Program will affect the number of total measures, activities, or entire categories that an individual clinician or group must report. These circumstances are applicable for clinicians in health professional shortage areas, rural, non-patient-facing, hospital-based, small practices, ambulatory surgical centers, and extreme and uncontrollable circumstances. Now for the performance period. The performance period requirements have changed for the quality and cost categories, as you can see. There is now a 12-month quality payment performance period, January 1st to December 31st, 2018. CMS changed this because they wanted eligible clinicians to report a full year of quality data to get a more complete picture of your performance and for the clinicians to have a greater chance to earn a higher positive payment adjustment. Also, the cost performance will be weighted in 2018 and now worth 10 points. The timeline for year 2. Performance year opened on January 1st and closes on December 31st. Deadline to submit your data will be March 31st for most submissions. CMS provides feedback after data is submitted. Historical clinicians receive feedback in September before the start of the payment year, which would be September 2019 for this year's reports. On January 1st, 2020, the positive negative 5% adjustment will be applied to each Medicare Part B claim. Now on to the reporting options. You can report 3 ways. As an individual is defined as a single clinician identified by their NPI tied to a single taxpayer identification number. Your payment adjustment will be based on your final score derived from the 4 MIPS performance categories. A group is defined as a single tax ID with 2 or more clinicians. At least one of the clinicians within the group must be MIPS eligible. Each MIPS eligible clinician in the group will receive the same payment adjustment based on the group's performance across all 4 MIPS categories. If you want to report as both an individual and a group, eligible performance categories, you can report the data as an individual and part of a group under the same TIN. In this instance, the clinician will be evaluated across all 4 MIPS performance categories on their individual performance and on the group's performance, with a final score calculated for each evaluation. The clinician will receive a payment adjustment based on the higher of the 2 scores. And lastly, you can also report as a virtual group, which is new for this year. A virtual group is a combination of 2 or more TINs consisting of solo practitioners who are MIPS eligible and or groups that have 10 or fewer clinicians. Again, at least one clinician within the group must be MIPS eligible. And we'll talk more about virtual groups next. So what is a virtual group? Again, a virtual group is defined as a combination of 2 or more TINs assigned to 1 or more solo practitioners, or to 1 or more groups consisting of 10 or fewer clinicians that come together virtually. A solo practitioner is a MIPS eligible clinician exceeding the low volume threshold and is not a newly Medicare enrolled MIPS clinician, a qualifying APM participant, or a partially qualifying participant. A group is considered to be an entire single TIN that elects to participate in MIPS as part of a virtual group. Virtual groups also have the flexibility to determine their own composition. There are no restrictions based on location, specialty, or other factors. So what else do you need to know? The election process. When solo practitioners and groups want to form a virtual group, they have to go through the virtual group election process. For the 2018 performance period, the virtual group election period opened on October 11, 2017, and closed on December 31st of that year. In order to participate in MIPS as a virtual group, the performance period begins prior to the year of the performance. Therefore, if you would like to join the virtual group in 2019, the performance period just began on October 1st of this year and will run through December 31st. More so, each virtual group must have 1, a formal written agreement between each solo practitioner and the group that composes a virtual group before an election is made. You do not have to submit this agreement to CMS. Again, it's just a formal agreement done between those practitioners. Next, you must name an official representative who is responsible for submitting an election on behalf of the virtual group to CMS via email. In the next slide, we'll list information on where to go to obtain the virtual group toolkit that includes a CMS virtual group email address for submitting this information and for more guidelines on virtual groups. The formation of virtual groups provides for a comprehensive measurement of performance, shared responsibility, and an opportunity to efficiently coordinate resources to achieve requirements under each performance category. A solo practitioner or a group may elect to join a virtual group in order to potentially increase their performance under MIPS. All groups will receive the same score and Medicare payment adjustment once MIPS is complete. And this last bullet below lists the URL for the virtual group toolkit that we just spoke about. Submission mechanisms. CMS has decided to continue the use of just one submission mechanism per category for year 2. In year 3, 2019, CMS will allow for the use of more than one submission mechanism per category, but for now it's the same as year 1. You can submit through a qualified clinically data registry, a qualified registry, through your EHR, or through claims submission. For groups of more than 25, you can submit through the CMS web interface, which most of you probably know as the GPRO, Group Practice Reporting Option. Now let's review each performance category. The 4 components of MIPS are quality. This replaces the PQRS. Improvement, new category in 2017. You'll see more activities in 2018. Promoting interoperability, formerly known as advancing care information, and previously meaningful use. Cost, this replaces the value-based modifier. First, let's review the quality category. The quality portion is worth 50% of your final score and obviously still carries the most weight out of any of the categories. Data for at least 6 measures must be reported on for the 12-month performance period, January 1st to December 31st, 2018. One of these measures should be an outcome measure. If you have no applicable outcome measure, you can submit a high priority measure instead. Submission methods are via claims, CMS web interface, EHR, CSV, or by CMS approved registry. If you are submitting quality data via claims registry or web interface and submit less than 6 measures or no outcome or high priority measure, CMS will use the eligibility measure applicability process, which they call the EMA process, to see if you could have submitted more clinically related measures. If CMS finds that there are no applicable measures for you, you will not be held accountable for not submitting those measures. We'll have a lower number of maximum points available. But if CMS finds that additionally clinically related measures could have been submitted and were not, your maximum number of points available for the quality performance category will not be reduced and only partial credit will be awarded. Quality measures that do not meet data completeness requirements, which is 60% reporting rate for 2018, will receive just 1 point instead of 3 points per measure. There's one exception in which small practices consisting of 15 or fewer eligible clinicians would still receive the 3 points. Each submission mechanism requires a minimum amount of data to meet data completeness requirements. QCDR, qualified registry, and EHR submission mechanisms require at least 60% reporting rate for all payers that are eligible, not just Medicare Part B patients or visits. The CMS web interface data submission mechanism requires that at least 248 Medicare patients randomly selected by CMS to be reported on for each quality measure. There are over 270 measures available to choose from via the Quality Payment Program web portal. And when selecting those measures, you can choose to only view measures that are specific to your specialty and reporting mechanism. As you can see, there are no changes in the quality measures, benchmarks, or bonuses in year 2. Benchmarks for a given measure are typically defined using historical data submitted for that specific measure. A clinician or group can receive anywhere from 3 to 10 points for each MIPS measure that meets the data completeness standards and case minimum requirements. Bonus points can be earned by a submission of 2 or more outcome or high priority quality measures. Bonuses, however, will not be awarded for the first outcome or high priority measure since that's required anyway. Physicians are eligible to receive 1 bonus point for each measure reported on what MIPS terms end-to-end through electronic submission. Physicians may earn up to 10% of the total available points if they submit measures through EHR, a qualified clinical data registry or web interface. To be considered end-to-end, electronic reporting and automated process must be used to aggregate the measure data, calculate measure, perform any filtering of measure data, and submit the data electronically to CMS. Systems that require any manual abstraction are not eligible for this bonus. As mentioned a couple slides earlier, to locate the quality measures that are required for your specialty, all you have to do is go onto the Quality Payment Program web portal and under the Quality Measures tab, select your specialty and reporting mechanism. And that will generate a CSV file with the quality ID numbers for your measure. To find the correct Category 3 codes, or as you may know them as CPTs or HCPCS codes, you can look up that measure ID in the CMS resource library. There are two measures in the cost category: the Medicare spending per beneficiary, MSPB, and the total per capita cost measure. The Medicare spending per beneficiary measure assesses total Medicare Part A and B costs incurred by a single beneficiary immediately, prior to, during, and 30 days following a qualifying inpatient hospital stay, and compares these observed costs to expected costs. CMS will review a minimum of 20 cases. The total per capita cost, the TPCC as CMS calls it, is a payment standardized, annualized, risk-adjusted, and specialty-adjusted measure that evaluates the overall efficiency of care provided to beneficiaries attributed to solo practitioners and groups. 20 beneficiaries must be assigned to the individual group SIN for this measure to be scored. The cost measure carries a 10% weight in 2018. CMS uses Medicare claims data to calculate the cost measure performance, which means clinicians do not have to submit any data for this performance category. This type of data calculation is not new. These two measures were used in the VM, the Value-Based Payment Modifier program, beginning in 2015. All groups received feedback illustrating how they performed on those measures in the annual Quality and Resource Use Reports, the QRUR, distributed by CMS. CMS will compare claims data to other MIPS eligible clinicians and groups. The cost category is new. There's not that much information out there by CMS. You do not have to report, but again, you will be measured against other eligible clinicians within your same specialty by these two measures. Now on to improvement activities. So the improvement activity is worth 15% of your final score and must be reported on for at least 90 days. 112 activities to choose from, separated in 9 subcategories. You can find all the improvement activities, again, on the Quality Payment Program website in the 2018 inventory list. For individuals, groups, or virtual groups with more than 15 clinicians, each activity is weighted either medium or high. To get the maximum score of 40 points for the improvement activity score, pick from any of these combinations: 2 high-weighted activities, 1 high-weighted activity, and 2 medium-high-weighted activities, 4 medium-weighted activities. And these could be within any subcategory. For groups, virtual groups with 15 or fewer clinicians, each activity is weighted either medium or high. To achieve the maximum of 40 points for the improvement activity, you just have to pick one of these combinations: 1 high-weighted activity, 2 medium-weighted activities, again, within any subcategory. A simple yes to a testing is all that is required in completing this activity. Again, I really want to harp on this one. This one's the easiest one to get your points on, so I want to make sure you do this one. There's 4 ways to submit your improvement activities. Small practices with 15 or less clinicians, again, will only need to report on no more than 2 measures. You can submit data any of the 4 approved ways. The data attestation will not begin until January 2nd through March 31st of 2019. If you want to attest through the Quality Payment website, you will need your EIDM login to do so. And again, you have to be doing this for 90 days. Now on to promoting interoperability. The promoting interoperability performance category promotes patient engagement, the electronic exchange of health information using certified electronic health record technology. The PI performance category replaces the Medicare EHR incentive program for eligible professionals. It gives you more flexibility when you pick the measures than the Medicare EHR incentive program did. In 2018, this performance category is now worth 25% of your MIPS final score. In 2018, there will be 2 measure sets to report on, PI objectives and measures, and 2018 PI transition objectives and measures. The option that you'll use to send in data is based on your Certified Electronic Health Technology Edition. You can report the PI objectives and measures if you have technology certified to the 2015 edition, or a combination of technology certified to the 2014 and 2015 editions that support these measures. The only performance score measure that you have a yes or no response to is the Public Health and Clinical Data Registry, the CDR reporting measure, and the Public Health reporting measure. MIPS eligible clinicians who are actively working with a public health agency or clinical data registry who submit yes for one of these measures would receive a full 10%. And clinicians and groups that exclusively report the PI objectives and measures will earn a 10% bonus for using only 2015 edition CEHRT, which is your Certified Health Information Record. Reporting yes for one or more additional public health agencies or clinical data registries results in a 5% bonus. So what if your electronic health record is decertified? If your performance period ended after the decertification occurred, you can apply for a hardship exception. Deadline for all hardship exceptions will be December 31st. And then which EHR edition do you have? We give you a really good link there. You can verify if it's up to par within the 2014 or 2015 edition. Go to that link and it will tell you. Performance threshold and payment adjustment. The performance threshold has risen in year 2 from the transition year. In 2017, you only needed 3 points to avoid the Medicare Part B negative payment adjustment. In 2018, you will need at least 15 points to avoid that adjustment. The exception performance threshold required for a positive adjustment will remain at 70 points. In 2018, the payment adjustment increased to 5% of a positive or negative adjustment on your Medicare checks versus 4% from last year. So again, from year 1, this was the transition year. All I needed was the 3 points to get away from the adjustment. Now you will need the 15-point threshold. It's really gearing into the MIPS now. Exceptional performance is set at 70 points, and again, we went up 1% in the positive and negative adjustment. Anything more than 15 points will get you a positive payment adjustment in 2020. Exceptional performers receive additional positive adjustment factors. Up to $500 million is available each year from 2019 to 2024. So MIPS and CMS is really trying to promote those providers that are really working on their MIPS scores and want to give out those bonuses. MIPS positive or negative adjustments will increase to up to 7% in 2019 for payment year of 2021, and in 2020 it will increase to 9% for the payment year of 2022. So it's really gearing in. The more we go down the road, they really expect all eligible clinicians to be really familiar with MIPS. How can you avoid the penalty? Again, you just need to reach the 15-point threshold. The general formula is points earned divided by total points in that category times the performance category weight. These are examples of how to earn the 15 points for a small practice. This is, again, 15 or fewer eligible clinicians, so there's multiple ways you can do it. We didn't really go over the bonus points that you get when you're an eligible clinician. It's an automatic bonus. We'll go over that a little bit down the webinar. However, just doing your improvement activities will give you 15 points. Scoring 4 to 4, you just need the 2 if you're 15 or fewer, if you're a small practice. And you can also just get the 5 points automatically as a bonus point. Option 2, you can do some of your quality measures, 3 out of the possible 60 points, and then half of the improvement activities, and you get your bonus there. These are some more examples of how to avoid the negative adjustment for small practices. Quality, do some of the quality there. You automatically get that 15 points, 18 out of the 60, and you get your 5-point bonus. And then again, if you just want to do a few of the quality measures and then some of the advancing care, and you get your bonus as well. Now, these are examples for large practices, 16 or more eligible clinicians. For large practices, remember that the quality portion must meet data completeness. 60% of all eligible patients must be reported on. Report each measure for a minimum of 20 patients. Do not get a bonus here, so it's a little bit more high-weighted. And you have to do a little bit more of the improvement activities. You've got to do all the 4, or do the 2 high and the 4 medium. You can do all your quality, you can do a portion of the quality and do improvement. Again, it's just a mix of how you want to do it. These are just some examples of how to avoid the negative adjustment. So we put together a MIPS action plan, 10 key steps for 2018. Step 1, determine whether MIPS applies to you. Review available performance categories, plan your MIPS participation, review your data, decide whether to report as an individual or a group that we talked about, choose your quality reporting mechanisms, performance security risk analysis. Step 8, you want to report at least for the 90 days or for the full calendar year if you're doing the quality. Step 9, complete MIPS performance, and step 10, submit 2018 MIPS data. However, in the next slides, we'll go over a little bit more in depth of how to make sure you really stay in touch with these action plans. So step 1 that we talked about, determine whether MIPS applies to you. Again, you are not MIPS eligible if you are newly enrolled in Medicare in 2018 or you see 200 or fewer Medicare Part B patients. You submit less than or equal to 90,000 allowed Medicare Part B charges annually, or if you do qualify as MIPS eligible, you must make sure that you are participating in 2018 to avoid the 5% penalty on your 2020 Medicare reimbursements. Step 2, review available performance categories. Review the performance categories and identify which categories will have measures that are applicable to your practice. Step 3, plan your MIPS participation. For 2018, CMS discontinued the 2017 Pick Your Pace transitional option. Therefore, if MIPS applies to you, it is no longer sufficient to report a single quality measure, as we have discussed, to avoid a penalty. CMS will determine your 2018 participation level based on the data you submit. Because 2018 is another transition year, CMS still allows a flexible option that is referred to as a limited participation track. Under this track, you can still avoid the application of payment penalty in 2020 for your performance in 2018 by achieving a MIPS total score that we just spoke of at least 15 points. Again, in the previous slides, we reviewed multiple ways to achieve at least 15 points on your MIPS final score. Step 4, review your data. To better understand how you may perform in the MIPS program and tailor your participation in 2018, review your past performance in other MIPS quality programs, such as the PQRS, the EHR incentive program, which was previously meaningful use, and the value-based payment modifier. You can use your September 2017 Quality Resource Use Report, QRUR, or your 2016 PQRS Feedback Report. This became available in late 2017 to help gauge future performance. These reports include tables that detail performance by group and individual and can help you understand how you've done in the past, how you might do in the future, and opportunities for improvement. Step 5, decide whether to report as an individual or a group. You can submit MIPS data as an individual or as a group to Group Practice Reporting Option, GPRO. Keep in mind, if you are an eligible clinician who is part of a group, your group does not have to report under a GPRO. The group is still under the option of having its eligible clinicians report as individuals. Step 6, choose your reporting mechanism. There are a number of mechanisms available for MIPS reporting that we went on, but we'll go into a little bit more detail. The qualified registries, these entities collect and submit clinical data on patients to CMS regardless of payer on behalf of clinicians. The qualified clinical data registries, QCDRs, like qualified registries, CMS approves these entities for tracking disease and patient data. QCDRs report on patients seen through all payers and are not limited to measures. CMS web interface, which is the GPRO, this option is only available for groups of 25 or more eligible clinicians who can report 12 months of quality measure data. During the submission period, the web interface now allows you to check your MIPS quality score, model potential scores based on different quality measures, and identify missing data. Groups using the web interface for the first time would have to have registered with CMS on June 30th, 2018 or before. You can report as an EHR as well. When considering EHR, ask your vendor about your dashboard functionality, which may help you track performance, whether the EHR is federally certified, and to what set of criteria you have, the 2014 or 2015 edition. If the available electronic quality measures are applicable to your practice, anti-data blocking attestation, and compliance with privacy and security requirements. Claims-based reporting as well. This is the reporting used on only Medicare claims and is available for individual physician quality reporting only. Step 7, perform and review security risk analysis. If you are reporting on the promoting interoperability category, you must perform or review a security risk analysis applicable to the 2018 to avoid an overall score of 0 in that category. However, entities that create, receive, maintain, or transmit electronic protected health information, EPHI, must complete a security risk analysis under HIPAA regardless of whether they participate in promoting interoperability. Allocate time to address any deficiencies to ensure that you can successfully attest. Step 8, report for at least 90 days. If reporting promoting interoperability or improvement activities, CMS deadline to begin collecting data would be October 1st, 2018 for those two categories, and or report for a calendar year if reporting quality. CMS deadline would have been January 1st, 2018 for quality. You can successfully participate in the limited participation track and avoid the 5% penalty by meeting all the requirements for a single reporting category, quality, promoting interoperability or improvement activities, or by reporting a combination of measures in different categories as long as they meet the 15-point minimum threshold that we kind of went over already. If you plan to only report on promoting interoperability or improvement activity measures, a minimum, again, participation period is 90 days is required, which means that you must have begun participating no later than October 1st. Again, unlike 2017, this 90-day period does not apply to quality measures. If you plan to report quality measures, you must report data covering the entire year. Step 9, complete MIPS performance. Make sure that you have met the data completeness criteria for your selected quality measures and to meet promoting interoperability and improvement activity requirements as required by your chosen participation track. If you don't have all the required data under the full participation track, please be sure to report on a sufficient number of quality, promoting interoperability, and or improvement activity measures to reach 15 points and successfully avoid the 5% penalty on your 2020 Medicare checks. Step 10, submit 2018 MIPS data. You should check with your chosen reporting vendor and or the CMS website to understand the due date for reporting MIPS data that applies to you. Submission due dates will vary by reporting mechanism. For example, the submission deadline is March 1st for those that are using the claims reporting option to report quality measures. Once CMS receives the data, it will have the information it needs to calculate your 2018 performance score for the purposes of determining your 2020 Medicare reimbursement level, ideally avoiding a 5% penalty and potentially receiving a modest upward payment adjustment and or qualifying for a share of the exceptional performance pool, which would be awesome. CMS has stated it will notify you of your score in the MIPS feedback report in the fall of 2019, but will attempt to provide even more timely feedback. This will be a really good way to track everything you're doing, so keep in mind these are the 10 essential steps for MIPS of 2018. So let's talk about some scoring and extras. In the wake of the hurricanes, CMS has added a new hardship exception for physicians that were affected by a hurricane, natural disaster, or public health emergency. So how does this work? If you were affected, you do not have to submit any data. They will be exempt from penalties. Meanwhile, those ones that do want to submit, your data will be reweighted. A hardship exception application is required, and that is due by December 31st, 2018. Again, we'll talk about the small practice bonus, which is really cool for this year. In an effort to further reduce the MIPS reporting burden for small practices, CMS will automatically award qualifying practices at 5 points. We kind of mentioned that earlier, so if you do have 15 or fewer eligible clinicians, you can get just an automatic 5-point bonus. There's also a new bonus for complex patients, up to 5 points available for treating complex patients based on medical complexity. These are measured by the hierarchical condition category, the HCC risk score, and a score based on the percentage of dual eligible beneficiaries. MIPS eligible clinicians or group must submit data on at least one performance category in the applicable performance period to earn this bonus. So you don't just automatically get it, you have to submit at least one performance category. So this is a great site. It's the Quality Payment Program web portal. That's the link to them. We did mention the Quality Payment Program quite a few times during this webinar. So I really want to harp on how important it is to get on that website and check all the information you need for your improvement activities. You can go in there and check all your quality measures, check if you're eligible, all that good stuff. And then if you need more information, they have a really good call center over there. I know a lot of people that have called them. They've got great feedback, or you can email them if you like. And then CMS also has a great resource library. It has a lot of ton of information and great guidelines, a lot of different fact sheets and all of that. So I really want to stress for you to go on that website, take a look, read some of those fact sheets, and get more familiar. Any questions? Okay, since there's not any questions, you can go ahead and email Kate Tingley at ktingley@coronishealth.com if you want any more information. And thank you for the time for this webinar.